I'm so glad to be here today. If you can't hear me, just raise your hand and I'll try to either get closer to the microphone or something. You hear me okay? Okay. All right, good. So I'm going to cover a lot of information today. I'm going to start by talking about kind of what a neuropsychologist is, and then what a neuropsychological assessment might look like. And then we'll also go through kind of what the difference is between normal aging versus mild cognitive impairment and dementia. So, and then I'll talk about a number of different types of dementia that we evaluate for in my clinic. So I've worked in the Tucson area since 2005. Finished my postdoctoral fellowship 2003 to 2005 at the University of Oklahoma Health Sciences Center. And so I was there for 2 years at the VA and then at the medical school, finishing up my residency. And then I moved here to start my practice. And pretty much the whole time my focus has been, or my love has been with dementia patients and their families. I do have a master's in marriage and family therapy as well, so I kind of came to neuropsychology in a roundabout manner. Not very many neuropsychologists do that first, but I think it has really helped me a lot because as probably many of you know, it's really tricky for family members to kind of navigate the waters with dementia and mild cognitive impairment. So, but either way, so in terms of the actual role of neuropsychology, as a neuropsychologist, what we do is we look at the relationship between the brain and behavior, and then how that translates into different types of disorders that we might diagnose through our evaluations. So a neuropsychological evaluation, essentially what we'll do, the patient will come to see me, we'll spend about the first hour in interview. After that, well, during the interview, I want to get a really good sense for their background, the medical history, any current symptoms that they're having. And then they'll be working with one of my technicians, typically after that, who will do the testing with them. And the testing consists of evaluations of memory, language skills, visual and spatial skills, problem solving, and processing speed and attention. So we take a look at all of those different areas of cognition, and then we look at patterns of test scores as compared to other people the same age, so we can see where strengths and weaknesses lie for each patient and what that might mean in terms of any diagnosis or treatment recommendations. People often ask, how do I know when I need an evaluation? So sometimes other people will let you know. Maybe you're forgetting things and they're noticing, I think we talked about that already. But sometimes it's if you're noticing either a mild change or maybe an abrupt change to your cognitive or other thinking abilities that, you just might want to get checked out. In addition to kind of, I always feel like it's never too early for someone to come to my office. If you're noticing mild changes, we can always establish a new baseline. And then, if things change down the line, we would have you to compare to you instead of just your scores to compare to other people your same age. But sometimes it's hard for us because we don't have a baseline to know exactly where people started off. So we use things like educational background, occupational history, things of that nature to sort of help us predict those things, but it's not 100%. So sometimes it can be helpful just to have that cognitive baseline. Sometimes I'll have a patient come to me. Now that I've been in the community for a while, I'll have people who come and they say, well, I saw you for ADD 15 years ago, but now I'm back and I think I might be having some changes. And I still have their report and I'm able to at least see how they were doing 15 years ago and what that might mean in terms of any changes to their thinking now, okay? So I've just touched on one, but some of the other specialties in neuropsychology are attention deficit disorder. We also evaluate, in addition to a whole host of dementias, we evaluate people for conditions like Parkinson's disease, multiple sclerosis. I have specialists in my office who work with kids and evaluate learning disorders as well as autism spectrum kinds of disorders. And then we have some specialty clinics as well, sort of. We have a provider who does evaluations for the FAA to determine appropriateness for people being able to continue operating an airplane, for example. And I also see some patients for pre-surgical evaluations, not only for deep brain stimulation for Parkinson's disease, but also for bariatric surgeries and spinal cord stimulator surgeries. So there are kind of a lot of different things that we do in our field. And I think most of the people in my office really, dementia is our bread and butter and our joy. That's what we all love to do. So why is it I can remember the lyrics to my favorite song in high school 20 years later, but I can't remember why I came into the kitchen? Anyone? Happens to me too. That's the most common complaint of normal aging, just so you all know. Other things that people generally notice just as part of the normal aging process, generally just some increased forgetfulness, some difficulties with multitasking and word finding, and a little bit slower processing speed, okay? In terms of normal aging versus mild cognitive impairment versus dementia, you can see there's sort of this preclinical stage where, there might be some brain-related changes, and the patient's saying, I'm kind of feeling like things might be a little bit different, but nobody else is really picking up on it yet, okay? With mild cognitive impairment, what we tend to see is that there might be one or more areas that are mildly below what we might expect for age and education, but people are still independent. In fact, whoops, here, I'll go ahead a couple. I'm too far ahead. Oh, maybe I took it out. Okay. Oh, there it is. So with mild cognitive impairment, we tend to see people who are independent for all of their activities of daily living. Things like management of finances, medications, they can still drive, but they're noticing some mild changes, or someone else is, okay? With a major neurocognitive disorder, which is the same thing as a dementia, what we tend to see is that people have become more dependent, or should be more dependent, for activities of daily living, things like management of finances, medications, and driving. And we're noticing more significant changes to their thinking that we think reflect a decline from where they've been in the past, okay? So so I just skipped over it. So in terms of differential diagnosis, there are lots of different things that can cause problems with cognition, and I've got a whole bunch of them listed here. Different types of dementia for sure, but there are also some metabolic abnormalities, meningitis, things, just lots of medication interactions, things like depression and anxiety that can affect cognition. So all kinds of things that we need to take into consideration when we see patients in our office. People often ask me, what is the difference between Alzheimer's disease and dementia, okay? Essentially, I feel like the easiest way to describe it is that dementia is sort of that umbrella term for a whole bunch of different types of dementias. So Alzheimer's disease is one of them. About 50 to 70% of people with a diagnosed dementia probably have Alzheimer's disease. It's the most common, and that's why probably most people know about that one. Vascular dementia is probably a close second, kind of somewhere 20% or so of people have vascular dementia related to things like high blood pressure, high cholesterol, maybe sleep apnea, heart disease, diabetes. All of those things are vascular risk factors that can affect cognition. And so then we have other types of dementias that are more rare. Frontotemporal dementia, only about 5% of the population has this, and there are a whole bunch of different types of frontotemporal dementia, as well as Parkinson's disease dementia and Lewy body dementia. So we're going to touch on these today, but there's just a lot of information. So there are some reversible conditions. If we're noticing changes to our loved one's memory, we're going to hope for one of these, something that we can do something about so that things get better over time. Normal pressure hydrocephalus is one of those, nutritional deficits, medication side effects, and things like subdural hematoma, which are pretty common in older adults. Especially if people fall and they hit their head, they can easily have a subdural hematoma that can resolve over time. Very often people get back to their normal functioning after some of these reversible kinds of things. Some other conditions that have reversible cognition, cognitive problems would be things like sleep apnea, fatigue, insomnia, those kinds of things, chronic pain, depression, and anxiety. Okay? So those are all things that we ask about in every single evaluation because sometimes there may be more than one thing going on. Okay? Prevalence of dementia. At 60 years of age, less than 5% of the population is diagnosed with dementia. There are some early onset forms of dementia, some of which I've already mentioned today, that tend to start in the 4th and 5th decades of life. Fortunately, those are really uncommon, okay? And then every 5 years after the age of 60, the incidence of dementia doubles, okay? So at 65, you have more. By the time people are in their early 80s, kind of 15 to 20% of people may have some type of diagnosable dementia. So the biggest risk factor for dementia is age. And, just we're all going to get older. And so the best thing that you can do is to take care of yourself so that some of the conditions like vascular dementia can maybe be warded off. Some of them are most definitely have more of a genetic component, or it's just a bad luck of the draw kind of situation. So these are some of the ones I've already mentioned, and I'm just going to move forward from this. The other couple that are on here are dementia due to traumatic brain injury. We see that both in younger adults as well as older adults. Car accidents, falls, things like that could cause a brain injury. What's that? Did someone say something? What? Football, yes. So CTE, or chronic traumatic encephalopathy, too. We can see that. In your neurologist's office or your primary care doctor's office, probably most of you have encountered one or more of these cognitive measures. I'm hoping so, because they're screening measures for cognitive impairment. So things like the mini mental state examination. It asks, it has people tell you what the date is, where they are, remember 3 words, remember them in a few minutes. And sentence repetition kinds of things, copying of a simple figure. The Montreal Cognitive Assessment is very much like that, but it's a little more difficult. Those scores can signal to primary care and neurology that there maybe is something that needs to be evaluated further, and then they may send people to us as a result of that. Most of our referrals come from neurologists and primary care physicians. Essentially, brain imaging takes a really nice picture of the brain, but it doesn't necessarily tell us how well it's working. And so what we do is we evaluate functional abilities to see where strengths and weaknesses lie and look at patterns of our testing that can help predict what kind of dementia people might be experiencing, or if they're not.
Could you explain that last one, please?
Sure. So the verbal fluency test that's on there, we have people quickly come up with words that either start with a letter, okay, or words that are in a category. And it's a processing speed measure, but also, with Alzheimer's disease in particular, people tend to have trouble with semantic organization of things. So putting things in a category is harder for people. And so we tend to see weaknesses in verbal fluency, categorical verbal fluency with Alzheimer's, versus weaknesses in phonemic verbal fluency with vascular changes. Not always true, but it's kind of a trend that we've noticed. We also often use a cube drawing test and a clock drawing test. I included a couple of the kind of normal looking clocks here for you. The numbers are well spaced around the perimeter. People have the hands in the right place to indicate a designated time. When we see things like this, we get a little more concerned. So a clock drawing measure it's a pretty simple measure of problem solving, but it's pretty sensitive. Sometimes people will put the numbers in the reverse order around the clock. Sometimes they'll write them right down the middle, like you see on the top right there. And sometimes they'll just write something digital off to the side. We can also use this for in cases where people have had a stroke and they have a visual field cut maybe on one side of their space. And so we may just see only the numbers on the one side that they can, that's the side they can see. And so they neglect the opposite side of space. So it gives us a lot of information, even though it's a simple screening measure. Okay. Any questions about that? Okay. So I already kind of talked a little bit about this, but in testing for dementia, we typically we schedule a 3 to 4 hour evaluation. It's a long period of time. Not everybody can tolerate 3 to 4 hours, but you're lucky if you're in for a 4-hour evaluation versus an 8, because some of our younger patients do 8-hour evaluations. So we do kind of take everybody where they're at. If they can't tolerate a longer period of time, we will definitely reschedule for another, hour on a different day, or break things up that way. We want to make sure that we're getting good effort and not just measuring how tired people are. So we're going to be flexible with you in that, but we have a lot of ground to cover in terms of the different measures that we administer. So we want to make sure to get as much of that covered as we can. Okay. So it can help us establish a baseline. We can track people over time then. So very often if someone comes to me and they're having some mild cognitive problems, I'll say, well, let's see you again in another year and we'll do another round of testing. Right now it seems like you're appropriate to live independently, manage your own affairs, drive, and then we'll evaluate in another year and see how things look at that time. If there are some recommendations that I have for people about cognitive therapy, or maybe let's work on your depression, get your mood better managed, something like that, I'll send people back to their primary care physician or their neurologist for them to implement those recommendations. So it really, every evaluation is very much tailored to the individual that's in our office. So any questions about testing in general? No? Okay. Oh, go ahead.
My neurologist has requested, what you're talking about, the testing, and they told me that it would be over a year before I could get in for testing.
Yeah, it is a problem. I think in our office, we're booking into February right now. So it's still several months out. Very often, retirees have a little more flexibility in their schedules, not always, but we also have a cancellation list, and sometimes I can't get to my front office quickly enough to say, don't reschedule me if I get another evaluation, I need a little time. But, each of us see about 6 to 8 evaluations a week. We spend most of our time writing and interpreting the results. And then, of course, the other pieces are interviewing and then providing feedback to the patients. But yeah, it is a problem in our community. And we have recently hired someone new to try to help us cut down on that wait time. But yeah, our receptionists were saying we're getting about 30 a day referrals. And there are 6.5 providers. So, you guys do the math, but it doesn't work out very well. So a lot of times people are having to wait. But, if we have a cancellation on an afternoon, very often, if we know ahead of time and people just don't no-show, we can say, well, find somebody else to fill that slot. Any other questions? Oh, go ahead.
Is the use of AI any possibility in any of this? Not that I appreciate.
Yeah, I don't know. We don't really use AI very much. I think it could be useful to us in writing our reports because they're often templated, but I don't know, I don't know, I'm old school that way. But we are doing a lot more telehealth, and mostly for interviews and feedbacks we can do that, especially if people are coming from Green Valley, or sometimes we have patients come from Yuma. So it's like, I mean, they come from a distance to see us, but we'll always offer that option for feedback so they don't have to make 2 trips. But other questions? No? Okay. All right. So, I always tell my patients we're looking for, we're comparing your scores on our measures to those of other people your same age. So if anyone has exposure to statistics, you're probably very familiar with the normal curve, right? So most people on any given variable are going to cluster in the middle, even height, weight, memory, intelligence, whatever. And so anything from about the 25th percentile to the 74th percentile is considered normal. Okay, that's average performance, all right? So, we expect that most of our patients who have a high school diploma minimally are going to fall in an average range, okay? It's not always true, okay? Very often I'll see patients who could have gone on to be a medical doctor, but they just didn't, but they're real bright. We give measures to help us predict where their scores might have fallen in the past. To try to, figure out where people started off. But that's the importance of having a cognitive baseline for us. So whenever we see scores that are down in a moderately to severely impaired range, we get concerned about dementia. When we have scores in a mildly impaired range or even a low average range, like if I have a physician in my office who's now being tested for dementia, and his intelligence or hers was previously at the 98th percentile, low average would be low for that person. Even average might be low for that person. But there's also quite a bit of variability for every person that comes through the office. People are going to have their own areas of strength and weakness. We can't always know for sure. So we look at testing patterns to help us figure out what might be going on. Where I start in the interview is just trying to get a good sense for what people are noticing. And in Alzheimer's disease, that's really important. So with Alzheimer's disease, what we tend to see, very often the patient's like, I don't know why I'm here. People say I have a bad memory, but I'm fine. Like they think everybody else's memory is bad, right? And the person next to them is like, they're not fine. And so what we tend to see, and what patients report and family members report, is a rapid forgetting of information after a very short period of time. So how that looks in daily life is people ask repeated questions. So what time are we leaving for the doctor? So what is this appointment about? And the answers are provided, and nonetheless, 5-10 minutes later, we're asking the same question again. The other difficulties that are commonly reported with Alzheimer's disease are word-finding difficulties. And as things progress, people have more trouble with visual and spatial skills as well. So there are early onset forms of Alzheimer's disease that can start before the age of 65. But most commonly, people are noticing these symptoms after the age of 65. Okay. I already started kind of talking about some of this. Usually people with Alzheimer's don't have Parkinsonism or tremors, that sort of thing, until late in the disease. They can experience those things. They're often pretty apathetic. People say, my husband used to be a go-getter and he was always busy doing something, and now he's just pretty content to sit around and not do a whole lot. So kind of their get up and go has gone up and went. But a lot of trouble with apathy, just not initiating behaviors or even things that they really enjoy. Yeah?
Do you think that has anything to do with retirement?
Sometimes I think it's retirement, but I think it varies from person to person. But I would encourage people to keep active as much as they can, because it's sort of like keep your mind active in particular, because if you do, you're going to have, you got to keep using it in order to not lose it also. So we need practice, and we need to read or whatever it is that's enjoyable to you. But yeah, I mean, this is more severe apathy, I would say, than what we would typically see with retirement, where people are just really like, and maybe it's confused for depression. Sometimes people think, well, maybe he's just real depressed. I don't know why he's sitting around like that. But it's usually a pretty significant change from how someone's been in the past. As dementias progress, we can see some agitation, some things like delusional thinking and paranoia, and people might start wandering. They may not recognize their home or be able to find their way around their home. They can start hoarding things, or have appetite changes, things like that as well. But those, I would say, are more in the advanced stages. We see more things like that. Any questions about that? No? All right. So I mentioned before, memory loss, word finding, categorical verbal fluency, sort of coming up with words that are in a category as weaker. Simple attention is usually pretty good. A lot of times processing speed is okay too. So, a lot of times I'm kind of tasked with, okay, their memory is in a mildly to severely impaired range, but otherwise their visual and spatial skills are strong, their processing speed is quick, their attention's okay. Can this person drive? Right? So, right. I mean, and sometimes the answer is yes in early stages, I think. If they still, especially in familiar places, those tend to be the places where people can get around longer. But, as I often start by saying, let's not, if you can get away with not driving and have someone else drive, that's probably better, or have someone else in the car with you. I'm not concerned that you're going to run into something, or I'm not concerned about your attention on the road, but I'm concerned about, are you going to wind up in Mexico or in another state? Because it's a real thing. It happens. So we'll talk about those things. And motor functions are often well preserved too, so reaction time's fine. So that's an Alzheimer's disease. With vascular changes, people tend to be a little slower. They kind of take their time, and their speech might be slower. Their reaction times and multitasking might be slower. So really different patterns of testing that we see as well. With vascular change, with Alzheimer's disease, we tend to see this gradual progression of difficulties over a number of years, okay? Sometimes even up to 20 years. With vascular changes, we see more of a stepwise progression. So people might be going along just fine, and then they have a stroke. And then they recover a little bit, and then they might have a heart episode or a diabetic episode. But it tends to be more of a stepwise progression. Okay, and so even with vascular changes, and I like this next slide, because it says, sometimes I amaze myself, other times I can't remember what day it is. And vascular dementia can kind of feel that way, where people are really good on some days and other days not so much. Especially if they have a condition like sleep apnea and they're not using their CPAP all the time. Most people don't like to use it, but it really can affect cognition pretty significantly day to day. Memory is really different with vascular changes than with Alzheimer's disease. People have more trouble getting the information to stick the first time, but if it sticks, their chance of remembering it later is really good. Okay? Really different from that rapid forgetting of information after a short period of time. So we look for those kinds of patterns in our testing. And then the other thing is, depending on, if someone's had a stroke on the right side of the brain and they're right-handed, we might see deficits of left side body function, weakness on one side. We might also see visual and spatial changes. We might see visual field cuts on one side. Whereas if they've had a stroke on the left side, we might have more of an aphasia presentation where people can't say what they want to say. It can be just expressive speech, but it can also be receptive speech where they can't understand what people are saying to them. So, and then the opposite side of the body is affected with a left hemisphere stroke. Did you have a question?
I just have an observation.
Uh-huh.
My mother had vascular dementia. And before she had that, she was misdiagnosed. They said she had low blood sugar. But I remember as I went back to watch her behavior before this even became, there would be times when you were talking to her and suddenly there would be like stopping and she'd like fade out and then she'd fade in again.
Yeah.
And they were treating her for hypoglycemia.
Yeah. And it could be that she was having TIAs, right? Transient ischemic attacks, where she was having little tiny strokes and then she was recovering. And you know, it's hard to say, but you know, very often that's an early sign that something isn't right. You know, so you know, I always tell my patients too, you know, having had a stroke places you at higher risk for having another one. So if you notice acute changes to your speech or your balance or your motor functions, or got drooping of one side of the face, or you can't see in one part of your visual space, those are all signs that you should get to the hospital as fast as you can, because there's a lot more that they can do if you get there early than if you wait. Okay. Oh, I should say with vascular changes, you know, if people have a lot of microvascular ischemic disease in their brain, where there are a lot of little tiny areas that look like tiny strokes or tiny TIAs, things can look a little more gradually progressive over time, just because of our patterns of testing tend to look the same, but we don't always see that stepwise progression. Sometimes with just the microvascular disease, we see more of a gradual progression if people have a lot of those microvascular changes in their brain. The next area we're going to talk about is Parkinson's dementia and Lewy body dementia. So Parkinson's dementia is characterized by a resting tremor. So I don't know if people can see me, but you'll often see people like this if they're not medicated, right? And they're just at rest, but their hands going. Usually starts on one side, might move to the other side, and then it can go right, left if it starts on the right. But it varies per person. But they also tend to have a shuffling gait, and may have really rigid muscles as well. So, you know, can't lift their arm above their head, that kind of thing. Or sometimes it starts with shoulder pain, because that rigidity is setting in and they may not be aware of it, but the hand's going and they've got the shoulder pain. It's often an early sign of Parkinson's disease. Now, not everyone who has Parkinson's disease is going to wind up with a dementia, okay? You know, about 20 to 40% of people living with Parkinson's disease have a diagnosable dementia, but 50 to 80% at some point will develop it. So it's more common that people are going to get it than not, but people can live a long time with Parkinson's disease without having cognitive problems. And they may never have cognitive problems. Some people just never do. Dementia with Lewy bodies is similar in the sense that people have Parkinsonism, which, by the way, you can have a tremor for a lot of different reasons. You can have it with essential tremor, where when you go to do something, that's when the tremors start, okay? Rather than that resting tremor that's just going all the time. But you can also get tremors with medication side effects and those kinds of things too. So just because you have a tremor doesn't necessarily mean that you have Parkinson's disease. So dementia with Lewy bodies also tends to be characterized by, well, there are kind of three core criteria for it. One is the Parkinsonism, and you don't have to have all three, by the way, but one is Parkinsonism. One is well-formed and detailed hallucinations. So the people that come into my office will say things like, yeah, there was a group of men playing cards in my closet last night. Okay? Or I see these people in my trees outside my window that are, you know, making all kinds of trouble. They might even call the police to get rid of the people in their trees, right? And so those well-formed and detailed hallucinations versus, like, a lot of times medication side effects, people might see things out of the corner of their eye that aren't there, and they'll be like, oh, what was that, But that's really different from what we see with dementia with Lewy bodies. The third criteria for dementia with Lewy bodies is people have periods of acute changes to mental status and levels of alertness. So they may be acutely confused it almost looks like a delirium if you have ever known anyone who's had a delirium, which is can be due to a urinary tract infection or something like that, where suddenly everything's really different. And then it resolves, okay? But they tend to have these repeat episodes of acute change to mental status as well. Like I said, you don't have to have all three. Very often, patients with dementia with Lewy bodies will start with the hallucinations and the cognitive symptoms will come later. Not always. And so a lot of it's just getting a really good history from people and trying to figure out, so when did these symptoms start and which came first, and those kinds of things, so we can get a really thorough view of what's going on. Frontotemporal dementia. There are two basic types of frontotemporal dementias. There's a behavioral variant of frontotemporal dementia, which is characterized more by like wacky changes to personality and behaviors. Someone might go up to another group of people in a restaurant and sit down with them and start talking with them, like things they never would have done before. And their wife is like, what is happening? On testing, they tend to have more problems with what we call executive functioning skills. So higher level thinking kinds of things, the clock drawing, other measures of problem solving, organization and planning, multitasking. Those are all executive functions that are often affected with the behavioral variant of frontotemporal dementia. The language variant of frontotemporal dementia, also known as primary progressive aphasia, is a condition characterized by a slow progression of language problems over time. So unlike with stroke, where suddenly one day someone has this weakness on the right side of the body and they can't speak, this comes on gradually over a period of, a year or more, and then it can progress over time. Over time, people often then do develop problems with memory, judgment, reasoning, those kinds of things. But very often, if they catch it early, they'll come in and only language is impaired. But other cognitive functions are within a normal range. Okay. Things like progressive supranuclear palsy, really rare condition, about 1 in 600,000 people. Really, really rare. Unfortunately, my mom had it, so I got to have a little too much exposure to it. But people tend to have vertical gaze difficulties where they can't shift their eyes up and down. They tend to have speech problems. And a lot of the motor symptoms of Parkinson's, where the rigidity is there, but not so much the shuffling gait. They tend to fall a lot, usually backwards. And so, another condition, just super rare. And the other three that are listed there too are kind of a combination of like FTD with motor neuron disease is sort of a combination of the behavioral variant of frontotemporal dementia with ALS. So then people have all these motor symptoms in addition to a dementia. So lots of really awful conditions. Fortunately, only about 5% of the population will have these things. A lot of times they do come on a little younger. Okay, so I feel like the most important thing that I do in my entire week is meet with people to go over their results. Because it's important to me that they understand what it is that the results show and what that might mean in terms of any recommendations that I have. I do make standard recommendations about whether I think based on test scores and their presentation, people can live alone, manage their own medications and finances, whether or not they should be driving. I don't yank people's driver's license, but I do say, our measures only correlate with driving ability, and driving's this overlearned motor skill that most people have been doing for, since they were 15 years old. So I would recommend that you have a formal on-the-road driving evaluation, because that's really the gold standard. I might recommend additional workup. For example, if I think there's an early type of frontotemporal dementia, I might recommend some additional brain imaging to take a look at more the frontal regions of the brain and see if there's some relative shrinkage of that part of the brain. I might recommend laboratory testing just to rule out things like vitamin deficiencies that could be causing some memory problems as well. I also do provide research opportunities for people if they're interested in, trying experimental treatments or things of that nature. Certainly we can get you pointed in the right direction for things like that if you're interested. And then just a lot of community and online resources that are really, really helpful for people. I did list a bunch here. And by the way, I'd be happy to send this to anybody if you guys would like it, the whole PowerPoint if you want. But the Alzheimer's Association has a lot of really terrific resources. The National Institute on Aging, if you go on their website, they have all kinds of digital forms of these kinds of things. I ordered a whole bunch like 3 weeks ago, hoping I'd have them to hand out. But they have pamphlets on all the different types of dementia that you can download and read through there. But you can also order copies for yourself if you want. And then the Association for Frontotemporal Dementia, there are Parkinson's Dementia and Lewy Body Dementia associations as well. Pima Council on Aging, I'm glad she's coming here because I think that'll be really great for you guys to experience working with them if you haven't already. I often recommend home care agencies, places like Visiting Angels in Beata and Right at Home. Different from home health, where the home health tends to provide more medical services, the nursing services. Home care is more like companion assistance, or maybe you need just some supervision while your partner's at work or partner is out running, doing something. So, they can, and they're usually, they're not cheap, but I don't know, unless you've got a long-term care policy, which I recently purchased one after my mom's dementia. She had one, and so I was really fortunate to have a lot of caregiving assistance because we lived together. But they can provide a lot of really good help in the home. I often mention hospice and palliative care agencies. It sounds really morbid, and most people kind of have this preconceived notion that hospice only gets involved in if people are only going to live less than a year or something. But really, it's designed for anyone who has a condition that is thought to be progressive and probably terminal at some point. So, but they can provide all of your medical care. They will, send nurses out to the house. They have chaplains that come if you want that. They've got, they can get you equipment faster than Medicare ever will. So we called for a bed and they brought it the next day, So things like that are just really, really helpful and good resources to have kind of in your pocket. I put some information on where you can go for a driving evaluation. The Department of Motor Vehicles tends to be pretty punitive. So they're more likely to just yank your license than if someone thinks that they can work with you to develop some skills to help you stay driving longer. Driving to Independence is a better choice for that. And then just some books and things like that on dementia and caregiving and those kinds of things. So, questions? Yes?
Are you familiar with the PYP test?
No.
Why?
What's the PYP test?
I don't know, that's why I asked. My wife got a call from her cardiologist who's working with vascular and they referred her to TMC to get a PYP test, and I'm kind of curious what that is.
Well, let's look it up. Oh, I'm not connected. Let me see. I don't know what that is. I can look into it though for you if you want.
I'll tell you what it is after next week.
After next week, okay. Fair enough. Yeah, I'm not familiar with that. There are things like Like for Parkinson's disease, a lot of times they'll do what's called a DAT scan that takes a look at dopamine in the brain and can help kind of narrow things down. Thank you. Pyrophosphate scan, nuclear imaging technique that uses a radioactive form of pyrophosphate to help diagnose cardiac amyloidosis. So it's a heart disease measure.
Because Marshall Cardiology was the referring doctor.
Yeah. Yep. Yeah. So, yeah, probably if she's got some heart problems, they're wanting to check out if there's, there are, so heart disease can affect cognition, obviously, and sometimes, we'll see patients who, if they've had a heart attack, they might have an anoxic episode where the brain doesn't get oxygen for a period of time, or a hypoxic episode where it gets only a little bit of oxygen for a period of time. So, and those kinds of patterns look really different on our testing too. I recently had a young kid who had a really bad case of COVID, and he was on a ventilator, 34 years old, on a ventilator, and he coded a couple times, and now he's got this anoxic brain injury and really can't function day to day because it really wipes out your short-term memory.
I have a similar neighbor like that,
Yeah.
33 years old.
Yeah, so sad. Yeah. Yep. Yep. Yeah. It's so hard. I mean, I think with COVID, what we're really seeing is that unless people are, put on a ventilator, or they, don't go to the hospital and probably should have, but they, their oxygen saturations are super low for long periods of time. Most people are recovering just fine from it, but those people who had a really bad go around and maybe were the ones in the hospitals for months at a time, those folks often don't fare very well. But that would be similar to any kind of like RSV or flu kind of condition where, you have to be put on a vent because you can't breathe. So.
I just want to put in a plug for the Parkinson's because I'm in and out of everybody's business here in the Valley. Mm-hmm. That group is really very, very good.
Yeah.
They have activities, they have sociabilities, they have information, and we're lucky to have them this close to home. And if you are having any of these symptoms, I'm sure that they would welcome you.
Yeah, we have some good organizations in Tucson too. There's a power gym that is specifically, you have one here too? It's designed specifically for patients with Parkinson's disease. A lot of that is just keeping your body going. And it can be really helpful to people to get those kinds of services. Water stuff too is great for Parkinson's. Oh yeah, go ahead.
I'm sorry. Will you put the last screen?
Sure.
On the resource screen?
Yep. And then you had a question too. Go ahead.
Just to say, first of all, that send me the PowerPoint and then I can
Okay.
send it.
Yeah, I'll do that.
But I guess the bigger question is, why get tested? I have people that say, I know what's going on. I know I'm experiencing all of this. There isn't anything that can be done. I mean, you can eliminate some things that
Right.
otherwise maybe, like a medication problem or whatever. But there's also a sense that, to what extent do you pursue this? And, there isn't, correct me if I'm wrong, but to what extent can that really help with any kind of treatment?
Yeah, so there are some medications that can help slow the rate of future cognitive decline. It can keep things from getting worse. You have to stay on it in order for it to be helpful. They do have some patch versions of it too now. And then there is a new medication called Leqembi that's actually showing some promise in reversing some of the symptoms and signs, especially if you catch it really early. So, there's a lot of research going on. Hopefully they'll put me out of a job someday, hopefully after I retire. But yeah, there aren't a lot of things that can be done to keep things from getting worse, but very often family members say, I just haven't known what to do, and I didn't know how much help he or she might have needed in any particular area. And so I think where we can really provide some resources are in helping families get what they need, and caregivers to get the support that they need, and navigating through all, and just understanding it better. You know, I mentioned before, sometimes with vascular changes, people are like, it's like they're faking it. One day they're fine, another day they're terrible. You know, what's up with that? But, you know, I think it helps give people a better understanding. Okay, so it's not just that they're not paying attention to me, or, you know, it's like once you understand what's going on and they're asking you for repetition again, you just tell them, you know? So, does that kind of answer your question?
Yeah, that's good.
Okay. Other question? Oh, go ahead.
In your, I'm sorry,
Yes, I was wondering.
questions, but that's what I do.
Oh, hang on one second. She was asking something in the back. Go ahead.
I was curious, have you heard of laser surgery for Parkinson's?
Laser surgery? Oh, like a deep brain stimulator kind of surgery?
I'm not sure, I haven't researched it yet. I
So,
heard of it today.
yeah, we do pre-surgical evaluations for deep brain stimulator surgeries and other surgeries for treatment of Parkinson's disease. And so, you know, essentially, if you're wanting to have a surgery like that, you should probably go earlier rather than later, because it's required in order to have the surgery. And you can't already have a neurocognitive disorder. You can have some mild difficulties, but if you've already got a full-blown dementia, your brain's probably not going to respond super well to a surgery of the brain.
What about Parkinson's?
Yeah, that's what that's for, is for Parkinson's.
I already have a tremor, and I got it shortly after I had the test for COVID. But who knows?
Yeah. Yeah, I'm not aware of any links there. I know that there are some links to Agent Orange from people who were in Vietnam.
I wasn't there.
Yeah, you're like, yeah, yep. Go ahead.
And I know you said age was the main factor, but is there anything in your experience, have you seen any genetic? I mean, do you see families kind of having this problem as opposed to otherwise?
Yeah, there's definitely greater incidence of, especially with Alzheimer's disease, of if you have a first degree family member with Alzheimer's disease, you have an increased chance of getting it, probably by about 40%. So it's a lot. But it's also, you know, there's, I don't know, the real strong familial types of Alzheimer's disease tend to be the earlier onset ones. So sometimes if people have them in their 50s, I mean, we can see patients who develop it in their 50s, like super young. Those tend to be more hereditary. Things like Huntington's disease, I don't know if anyone's ever heard of that. It's another type of neurologic disorder. A lot of, it's a movement disorder also, but writhing movements of the arms, and it's, if you have a parent who has it, you have a 50% chance of getting it. So, I mean, it's like, yeah. So, yeah, it is really high. And so, you know, in that disorder, the suicide rates are really high because people, it's a terrible disease they don't want to live with. So, yeah.
My 42-year-old grandson is having the brain imaging, or the brain one, for Parkinson's on the 21st of November.
Okay.
So, and he's very active, he bicycles and
Yep.
everything, he has to try to control
Yeah.
what he does, so
Yeah.
I'm very excited about him being able to control those stimulation.
Yep. Yeah. Well, and, you know, I mean, we all know who Michael J. Fox is. I mean, he's had Parkinson's disease for a really long time. And, you know, a lot of times those earlier onset ones tend to be very slowly progressive. You know, if people get them at an older age, they progress a little faster, but they can still progress over a period of, you know, 15 years or something too. So, yeah. Mm-hmm.
Karin, could I answer my own question?
Sure.
As I'm thinking about it, the value of, say, getting is partly for the caregiver and for them to be able to have a common understanding of what's going on.
Absolutely.
This just as what I'm thinking this is where it's really important. And I remember we talked a little bit about the fact that you've got this counseling background also. So we're working with, the caregiver and the client so that, there's a common understanding. I know that's true for my sister whose husband has dementia. And it's like, I need to have confirmation, and so we can somehow get on the same page.
Yep. Yeah.
We can build a team together.
Yep.
Even if you don't have that peer, you can do a better job of being a family unit.
Yeah, and just some, learning some skills, or, if someone says, well, you really shouldn't be driving, that's different than the wife saying you can't drive, or the husband saying that. It's a lot. I'd much rather be the bad guy than have my caregivers have to do that, because it's a hard thing to do.
So we are at the end of the hour. Karin is available for a little longer if you want to talk with her individually for about another 20 minutes.
Yeah.
And then needs to run off. But I'm very appreciative of her coming all the way from Tucson.
You got it.
So we're very grateful and appreciate so much your being with us today. So
Well, thank you so much for inviting me. So I appreciate that.
All right, so just remember, December 18th will be the next one of these, and a week from today is our memory cafe.
We'll have a lot of fun.